Welcome to Health Law Talk, presented by Shahardy Sherman Williams. Health law broken down through expert discussion, real client issues, and real-life experiences. Breaking barriers to understanding complex healthcare issues is our job.
Good morning, good afternoon, whenever you're listening to this. This is another edition of Health Law Talk here at Shahardy Sherman Williams. Conrad Meyer, Rory Bellina, bringing you the latest and greatest in healthcare legal discussions here in Metairie, Louisiana, overlooking a beautiful, gorgeous day pre-Jazz Fest. If you know if you know what that means, if you're a local, or even if you come here. And today we have a special guest in the studio, Dr. Katherine Williams, an OB-GYN. On the North Shore, right? Dr.
Correct.
Williams? Okay. Who is here to talk to us. This is sort of a follow-up to a podcast Rory and I did on vendor agreements. And Dr. Williams has a very unique experience over the years in her practice as she's watched it grow. And I'm going to get her to talk a little bit about that. So, Dr. Williams, for the listeners here who don't know you, introduce yourself, tell us a little bit about your practice, your background, and give them an idea about who you are and why we're here.
Okay, thank you, and thank you for the opportunity. I am a practicing OB-GYN on the North Shore in Covington, Louisiana. I actually started my practice on the South Shore, but relocated to the North Shore in 2003. I have built my practice to now employ 2 doctors and 3 nurse practitioners. So it's been a journey, and I've learned a lot about running business and about running a successful practice. And so I'm happy to be here to share that experience with your listeners. I hope that it does benefit them.
Oh, I'm sure it will. I'm sure it will. So let's get to the meat. Tell us about sort of why we're here, and what are the takeaways that listeners will learn once they get to listen to this podcast.
Right. So I also want to say that I am past president of Louisiana State Medical Society, so I've been in a unique position to watch and recognize that many physicians who enter private practice struggle with the idea of running a business. It's a little overwhelming, and also the lack of knowledge base to really know the pitfalls and the things that you need to be aware of. I will say this, and this is not necessarily a plug for you, but my best friends are my accountant and my attorney, because you have to make sure that you have them on your side so that you make a good decision. That small, I'm not going to say small investment for your attorney and your accountant will pay tenfold, because if you make a wrong decision, it could cost you a fortune. And I will share my experience with you on that.
I love that. Well, I mean, I got to tell you, it's hard for us because, well, number one, Rory, I'm sure Rory and I would both agree with you that having competent counsel and having that relationship is very critical for your practice.
Yes, absolutely. So I finished my residency at LSU in 1998. Originally, I was self-employed for a little while, joined a group on the South Shore, but relocated to the North Shore, as I said, in 2003, and went into private practice for myself again. Started off by myself, sole practice, very difficult. And as I started to grow, I built an office, and then I hired a nurse practitioner and ultimately hired a physician. This was about, I believe, 2010. Shortly thereafter, we understood that to have equitable reimbursement, fair reimbursement from the insurance companies, there was a mandate that you had to have EHR, especially if you wanted Medicare reimbursement, or you would have a fine or a penalty or a reduced percentage. So it made financial sense for us to then implement EHR. Prior to this, we're strictly paper charts.
Right.
Not knowing much about it, and there were a few vendors out there. Did some research and found different companies and did online consultation with them and discussed what products they have to offer.
Okay.
We signed our first contract thinking we were getting a great product. Within 2 years, we realized that we were basically sold a box of pancake mix and that we had to make all the pancakes ourselves. And when I say it was bad, it was really bad.
So let's call that vendor one, all right?
Vendor one.
Vendor one for EHR. So I mean, obviously you're smart, you're entrepreneurial. What did you learn? In other words, what research did you do, and then what sort of did you start to realize, like you said, you got the pancake mix, but then suddenly you realize that you're doing all the work? How did that evolve?
Well, what we learned then is that there are different companies with basically different stages of development. So just because somebody says we offer all this, you really have to ask more questions. How long have you been in business? What templates do you have? How many OBGYN customers do you have? These questions we didn't understand, and come to find out they were basically a beta, and that they did not have a fully established product. So they were relying on us to create templates and mechanisms within their EHR for it to function properly, and yet paying a lot of money. And so whatever you enter in, whatever product you choose, keep this in mind. It's going to cost you a lot of money to implement. So irregardless of how much you're paying for that product, go ahead and add on a few $100,000, because that's how much time it's going to take. It's going to cost you patience. You will not be able to see your full patient load. And it's going to cost you staff hours to do all the computer work, or whether it's scanning your paper chart. So I'm talking a couple $100,000 investment. Now, in the long run, it's going to pay off.
When you onboarded this company, how did you find them? I guess, did you hear from them from other colleagues? Was it simply that they reached out to you? What's that process like? Because I just got this question last week from an up-and-coming practice, and they said, we want to know which vendors or EHR vendors to go with. And I was like, well, I know who, some of your competitors essentially use, and these are like the big names. But besides that word of mouth, how did you approach it?
Right. So understand that when I first looked, it was the beginning of the EHR movement. I don't believe that there was that mandate in place yet, but it was the beginning of it.
Sure.
So the resources back then were limited. Most of it was online searches, reviews, but most of that has been doctored by those companies, that they'll pay for that promotion.
Right.
I've learned a lot about that now. The best way to find out about it today is to talk to your peers. I hope through LSMS, this is one of the programs I'd like to develop as chairman of the private physician section for LSMS, that we do have ways for physicians to learn more about EHRs that are out there, have maybe doctors that have it that they can talk to, and also working with attorneys to make sure they know how to properly represent their patients, because it's complicated. I've learned even so much more since last time we talked.
So most of the standard billing contracts require some percentage, right? And then they have they have a percentage fee only if you meet certain types of benchmark receivables. And then if not, then it's a flat fee underneath that. Is that what you started with?
Not necessarily. So that's what I'm going to tell you about the different product lines that are out there and the different types of billing that they can do, and then the questions you need to ask. Moving forward in that company, we did get out of it. We ended up having to sue them. It was terrible.
So wait, let me get this straight. So you create the templates for their billing people to then submit the claims. Then who worked the claims? In other words, who worked the denials? Who worked the recoupments or the refund? Who did all that?
We did all of that.
So in other words, they didn't even work the claims.
All they did was give us an electronic record that we would basically document on, and then that was it. We had to do everything else after that.
So you submitted to the payors yourself too?
Yes.
So
again, this was the beginning of the. Let me correct that. We had a separate billing software program,
okay.
But they were integrated, but not fully integrated. So again, what we realized was there were significant limitations, and that.
So you had to produce the claims within the EHR, then move to the billing program to submit to the payors. Is that right?
They were integrated, but not fully integrated, and so that again.
That's a problem.
But they promoted integration, but. What I've learned is it's really best to have the same company do both to really have an effective EHR program.
Sure.
Right. I'm with you. Okay.
I know of a few practices that still do paper claims. A lot of them are obviously shifting because you want that higher reimbursement and that MIPS, and it went on to stage 2 and 3. You talked about the burden on your staff and like the lost revenue. What was that process like for you and your staff when you said, we're switching from paper to electronic. How did that
How'd they
go
handle
over?
it? Right, that's a good question.
So that was the beginning of, again, that was when I had one nurse practitioner, myself, and one other doctor. We had a smaller staff. I mean, everybody, we have a great staff, and we just all work together to get the job done, and they really do take good care of me. I love my staff.
So once they knew that they had to do this and learned how to do it, they rolled with it.
They did roll with it, but of course I had to pay overtime, incentives. So again, it costs
You're paying
money to
Right.
implement. Correct.
Right.
Yes. Moving forward, we then started looking at other EHRs and learned a lot more about how to vet and research and knew the right questions to ask.
Okay.
This would be vendor number 2.
Okay.
Here we go. All right.
Here we go. And I would say that for the most part, we were in a honeymoon phase. We just thought this was the best. So what we did is this is an EHR that included billing and practice management.
Okay.
Now, when you were asking me about paper claims and about billing programs, you can have anything from the basic, where it will create a ticket that will be then sent to the insurance company for billing, but you can also have other services that will really save you money and time and allow for more efficiency in your office, such as insurance verification, so that your schedule then is looked at by the EHR or the vendor that you've hired to make sure that all of them have valid insurance policies.
Oh, wow.
It goes even a step further. It will tell you what their copay is, so that you're getting your money on the front end.
You're collecting the proper copays, you're verifying.
And if you look, I want to say, I'm sure the numbers have changed, but for every bill that you have to submit to go try to get paid for a service you had provided, it's like $9. But if you get and it might be more now with inflation,
Sure.
but if you get the money right when the patient presents, you're then also, you're keeping that money, which you should.
Right.
Because you're not getting extra money.
It's your money.
It's your money,
It's
exactly.
your money.
So to collect money on the front end is of the utmost importance.
Sure.
The other thing that they do is they will then submit it to the insurance companies that almost in the majority of the cases will find some reason to deny it.
Sure.
This number's not right. This code's not right. We're not going to pay for this code with this procedure code with this diagnosis. So they have companies that also offer service to what they call fixed denials or sweep, to make sure they're clean claims. That's what a clean claim is.
And that's what I tell physicians when we're talking about payer agreements. That definition of a clean claim is so important.
So important, because otherwise you have your staff sitting there trying to figure out what's wrong with it.
Yeah.
Okay? So now we've saved money on your check-in people, not having to verify benefits, knowing how much to collect up front. You save money on your billing people, and now you've also saved money on your billing people not having to go fix a claim. All right. And then it's submitted to the insurance company and you receive payment. It goes into a clearinghouse. Mm-hmm. They collect all the money for you and then they move it into your bank account. But there's one other part to this. It is posting payments. So they also can offer a service where they will look and see what you got paid and which visit or patient that's assigned to, instead of having your person in the billing department have to go through every claim, which sometimes in a practice of my size, there's several hundred a day.
Right.
They'll go in and they'll used to have to manually do that. Now these programs, these EHR practice management programs can do that for you.
And you mentioned practice management, so this is also handles like your scheduling and coordinates kind of your flow of your day, or what other practice?
No,
or does
all
not do
they
that?
do is they provide a template for that. You still have your office people that does take the phone calls, schedules the appointments.
Okay.
There's even other components to an EHR that you can pay extra for. Like one of them will let you, which we have some of these, where on presentation the patient takes an iPad and they will check off everything in the review of systems list. And then it's automatically downloaded into the EHR, so that now you've saved money with your nursing staff not having to sit there and get that, orally.
It generates the super bill automatically.
I just
I think that's
yeah.
incredible.
I've been to somewhere recently that had that. They
Yeah,
give you the
that's
iPad
right.
on the check-in. That's nice.
So
That's
so
a good
it
feature.
really is. It really is a nice service that we also utilize. There's also another I'm just telling you this because this is basically, you can go anything from just the basic EHR, the basic billing, to something that really helps you reduce your
You
staff.
go to the platinum package.
The platinum package,
There you
exactly.
go. All right, there we go.
And then I was going to say,
We're in the
there's-
wrong business,
right?
Rory. I mean,
No, really, you're not. But then there's another one that it actually will. I was going to get me distracted, where it will call your patients and give them reminders the day or
seen
2
those,
days
the
before.
texts.
I've
So
seen
those
that
are
too.
all upgrades. Right?
Okay.
Yeah.
Okay.
Now,
So it sounds like number 2's been great.
not necessarily.
Okay.
okay.
Vendor number 2 has
necessarily.
not been great. Okay.
No,
Okay.
not necessarily. So here's where I learned more.
Okay.
Number one is that.
Oh, I have one question before we get to
Yes.
that, because this always comes up when I'm reviewing vendor agreements, and I always punt this back to the client when it gets to the hardware section. They say your computer must be this, or you must have this type of server, this type of
Correct.
internet speed. In choosing those, is that pretty easy to handle? You just give that to your IT person, and they usually are
Right.
okay, or is there anything that's really you got to look out for?
Right. Yes, you definitely want to have a very competent IT person who is experienced in healthcare. We have had a couple. The most recent one actually does IT for other healthcare institutions and really knows what needs to be done, the firewalls and such. So don't rely on EHR. They'll tell you need this equipment, but you must get an IT person to make sure that you are HIPAA compliant. Because if not, you're also facing
OCR.
big fines.
Sure.
Yeah.
Sure.
So that's a big pearl that I would want
Okay.
to share.
So no real hardware issues besides just making sure that you've got the right hardware.
What we do, you can choose, there's many different ways you can do it. Some people prefer iPads and they'll walk in with their iPad to do it. What we do is we have a computer in every clinic.
Sure.
In every exam room. And then we also have laptops outside that the nurses use. Are a little bit more mobile, and at the nursing station and at triage, and of course all the check-in people have computers. And I prefer it that way. My partner, she likes to go in the room, talk, and then come out and do her work at her station. But I like to open and complete my visit in front of the patient.
So this new vendor, we're from a vendor number 2 now, right?
Right.
And you've got all these packages, these add-ons.
Mm-hmm.
How has it improved your patient encounters with respect to time with patient?
Right. So let me just say vendor number 2 was more of an all-inclusive thing. That there
Got it.
wasn't like there was a couple of add-ons that we did, such as the iPad.
So it's take it or leave it, all inclusive. This is what
Majority
we got?
all inclusive. The only things that were add-ons were the one with the where they took the iPad and they did their review
Right.
assistance. So we have a different vendor that does that.
Okay.
But they are approved vendors that have relationships with this EHR company.
So it then it's compatible. If you
Yes.
get, okay, got it.
Yeah.
Gotcha. Okay.
So when we interviewed this company, we didn't just interview them. We interviewed several of them. We chose this company because they had the majority. They had the most clients in our state that we knew, and everybody that was using them was happy with them for the most
Okay.
part. So we didn't get any complaints or
So you
concerns.
did your homework. You called your peers.
Yes, I did. That's really important. Then, even in the contract negotiation, I did not use an attorney. And so I handled it most myself, but I felt fairly competent that I knew what I was talking about this time.
We're gonna put you in a penalty box.
Yes,
I mean,
you should. And so, but what I did do is I did negotiate a reduced percentage. Now, this company takes a percentage of your collections.
Yes.
And so, right now at that point, we had not utilized their product, and we're like, no, this is too much money. This is not what we think it's worth. And so you can negotiate. I just want to put that out there. You can negotiate. The contract was pretty straightforward. It was like 3 pages, maybe 4 pages at most. It
Right.
didn't seem very complicated. I did see that it said that if I had a dispute, that I had to use a lawyer or mediation in the state that they were located. I didn't think that was the issue. It would be an issue. Now looking back, I wish I had gotten counsel, and I wish that would have been changed, because living in Louisiana, it's just cumbersome as a physician to go and get an attorney in another state. You don't know them. You don't feel comfortable doing that. And so it really puts the physician at a great disadvantage if they have a problem.
And maybe this will make you feel better. I don't know if Conrad will agree with me on this, but when I get to those provisions in these vendor agreements, that's always the one that I ask to be changed, but I rarely expect for it to be changed, because some of these companies are so big, or they've spent so much time, money, and resources in developing their systems, and they're based out of New York or Pennsylvania or Ohio, wherever it may be, and they've got their in-house counsel or their legal team, and they're not going to want to hire, if something goes wrong, they don't want to hire someone here. So it just depends on, I think, who it is, how much the vendor agreement's worth. Like, if it's the cleaning company that's coming in, they'll probably agree to go with Louisiana because they're cleaning everything in Louisiana. But on some of the bigger stuff, I don't have a ton of success on a track record from getting it changed. I've got zero success.
They don't want to change that at all. I agree with you on that.
So then I would say, as a physician or as a physician advocate, how do we make sure, empower physicians that they're not always on the what's the term, but they're on the bottom, not in a good place to negotiate after they sign the contract?
Well, I would say the strength in numbers. So if, in other words, let's just say the vendor number 2 is used by 50% of the market share here in Louisiana, and since maybe with other powers that be through LSMS or somebody else, you can collectively get everyone together and then collectively argue that, hey, for these 50% market share, then we're going to require you to have venue here. Now, I mean, that's, every contract's different, every renewal's different, but maybe empowering through the market share and using some other avenue to collectively coalesce everyone together might be helpful. I don't know.
Or legislate.
Well, we could. We could do that too.
We'll be working on that.
That's just a tough one, because really their people, like their servers, their customer support, they're probably all in that state that they're picked. So I don't know if that made you feel any better or not.
Have you ever had success in changing that?
I've had success in changing it when it's been a national company with like a smaller sub franchisee,
right?
Like a national cleaning company,
but
and then they've got franchise. But no, with those they always
billing company.
No, those they always want to stick with where they are.
It would be really great if there could be some provision just that would allow an avenue that was easier for the physician. And I put this out to you guys as the attorneys, just whether or not it's that you can have a representative that they would be willing to work with, or some,
maybe a fair ground, a middle ground would be, prevailing party would get the attorney's fees. So in your case, you have to go out of state.
That's a great idea.
Go out of
state.
We
see that. We could do that.
You would have to go out of state to New York, but if you're successful, they have to pay.
They have to pay all your
I like that idea.
So
and costs.
Yeah. So after having a relationship with this EHR for, I would say, 7 years, and my practice is thriving, doing very, very well. We've actually gone on to hire another doctor and 2 more nurse practitioners.
Great.
So we have
That's
6.
fantastic.
We have 6 of us.
This is vendor number 2 still, right? Okay.
Yeah.
All right.
We received a notice without warning that they were increasing our percentage rate due to inflation.
Percentage of collections. So
so that the way they bill is percentage of collections.
Okay.
There was nothing in the contract that previously provided for that. And so the only way that it could be forced upon us would be that they would then throw the termination clause at us, that they have to give us 90 days notice and they will terminate us, which we were told if we didn't agree, that would be the avenue they would probably go down. It really opened my eyes. I didn't realize how beholden I was to a company that I now relied on to deliver care to my patients.
Right.
And that
they had you over a barrel.
They did. Yeah, they really did. And that's a problem for physicians, and that's because you are mandated to use this product, but then the product, these companies, and some of them predatory, companies, are then seizing that,
right,
and then keeping us
at bay. Yeah,
and they know
they
what
know
their
that.
competitors are charging, so they're probably staying in that range. But they also know that if you were to, if you were unhappy enough, sure, you could leave and go to vendor C, your third one. but you're going to have to start over again with
which will cost at least a couple $100,000,
Correct.
at least. So that's where the dilemma is.
And they know that.
The other thing is,
it's like the donut hole.
And
right?
I have to say, it hasn't been a perfect relationship. We've had some issues. We have current issues that we're trying to work through. They are eagerly trying to fix it. I don't want to say that this company is bad. I'm not happy about this percentage. I do not think it is right or fair.
Well, let me ask you this. Aside from the percentage, one of the things that I know that I would track as an administrator for a hospital was my days receivable. I want to know that number. I want to know how many days are my days receivable, because I'm trying to get it back. This is before EHR. Back when I was doing it, we were trying to get under 60. If you were under 60 on paper, days receivable, you're doing phenomenal. Now I don't know what the number is, but do you look at now your days receivable number from your billing in EHR?
Absolutely. So this program, and almost all programs allow you to do that. You can put filters in and see what your days receivable is for like 30 days, 90 days, more than 90 days. And so this is what we learned about this vendor number 2.
Okay.
When I said that they do everything, we learned they didn't really. We thought, okay, they're going to do billing, they're going to do, but what we found out is that when the claim came in, yes, they did correct claims that weren't clean, but things we didn't get paid on, we had to go hire other billing people to go get that money.
So they would not, what I call, work the claims.
No.
Okay.
So then I was like, oh, wait, okay.
So once it was denied, that was it, and then you had to go.
I had to go hire 2 more billing people who then had to knew how to work this EHR to go collect the money, and so then that was more money. So but it was not promoted as such. It was, hey, we're practice management, we're going to do everything, but that's not true. You have to go work your receivables.
Yeah, because I'm sure if you put it in the contract, what happens for a denial, right, or a recoupment, right, or a refund? How are we doing that? Who's working that? How often are they working that?
In this,
did they go to second level appeals? How far do they go down? And none of that is ever addressed in the contract.
But I haven't met a vendor that would do that.
Right.
But that is not the way that they marketed their product.
I see.
So that, and even doing research, because I do have another vendor that I've looked at, and I'm going to tell you about that vendor shortly. But in this situation, we learn we have to basically do all of our denials and then try to collect that money.
So have you been happy with the switch to EHR since going from paper to this?
It was an adjustment, but now, yes, I can say I'm very happy, and I couldn't see myself going back to paper.
That's what I would.
Everybody says that too.
It was really hard at first, but now just the fact that I can just press a couple of buttons and look at a trend or a visit that was just 2 years ago, and now I go, oh, just let me click that button and look at that.
Well, one thing, if they've already pre-approving or authenticating insurance coverage, and you're collecting the copays, then you're maximizing in your mind all of the cash flow operations in the practice to the best of your ability, even though now you're having to work the denials.
Right. Well, but it's also a little bit more complicated than that. You have to be on your toes at all times. You need to make sure you look at your receivables and see if there's any things that stand out that do not seem right. I will give you an example. I want to say this was about 3 years ago. We all of a sudden notice, I'm not going to say the insurance company, but one of the biggest insurance companies in Louisiana, and that all of a sudden our payments went down significantly. Made no sense. Now, we then contacted our EHR. They're like, no, I don't know. So we then had to go investigate on our own because they were not aware of this. Turns out that insurance company changed a number. So all of a sudden we weren't getting paid on any of our claims. We don't see any other reason why that number changed.
When you see change a number, you mean like on a CPT code or on a fee schedule? What happened?
No, on a physician ID number. Like, in other words, you have a Medicaid provider number.
Right.
Like they'll change that number so that all claims had denials.
Oh, wow.
Now, is it a wonder that all this happened in December? It's
the end of the year.
this is just one example. I could give you a few others of these little glitches that happen. And so then we caught it.
So people understand what that means, though. In December, toward the end of the year, your patients have run through their deductibles, and so then it's incumbent upon the insurance companies to start paying out of pocket.
Yes.
So for those of you, why we're saying remember December, it's because that end of year Q4 is always the same thing.
There's quite a few little, what we believe, tactics to help slow down payment to the physician. And so you need to continuously have an advocate who's going to look at your numbers to make sure that you are being paid. Do not rely on your EHR to do that.
So you have a practice manager, actually, then?
I have an office manager, and then yes, I call her my chief operating officer, but she oversees everything.
That's great.
Yeah. So after skip forward, but after dealing with vendor number 2 and this proposed rate increase, then we started researching alternatives.
Okay.
To see, are we paying too much? I don't know if it's appropriate to say how much I actually pay for my EHR, but the numbers are astounding.
What did you find when you looked at other vendors? Is vendor number 2 comparable to what other vendors are?
Well, found out I decided to research vendor number 3.
We don't want to talk about. Let's not talk about percentages or anything like that. I want to
no.
So
right.
let's keep it generic.
No, but vendor number 3 is the largest EHR provider in the entire state. So I decided to go ahead and research that one and see what I could find out. If I actually use that EH program, I would have significant savings. I would say 80%.
Wow.
That's a big deal.
Based on because their percentage is lower? What are the savings from?
So what's interesting is how this product works. This product basically pays you pay a fee to start up, and what they call, installation.
Like an onboarding initial.
Initiation.
Gotcha.
And then you pay an annual fee, which is then paid quarterly. Okay? Significant savings. But here's the problem. It is, again, a very basic. That's all they do is it's a place to record your EHR, and then it would then create a super bill to submit to the insurance company.
Okay.
But all of the clearinghouse, the insurance verification,
posting, all that.
None of that's done.
So that's how they're getting away with a flat fee, because they're not collecting, so they don't take collections.
Right,
they don't
right.
work it, right.
So we're like, well, wait a minute. If we're going to make a change, we want to click a Cadillac again, or a Porsche, or whatever you want to call it. Okay.
Sure.
So we started looking at.
You don't want to go backwards. Your staff is going to kill you if you go backwards.
Exactly. So we started looking at other if this product offered
add-ons.
Add-ons. Thank you. And we found out they did.
Oh.
But and there's 2 so far. We've interviewed 2 different companies that have told us that they basically do it all. Okay, and they are integrated with this vendor number 3.
Okay,
they charge by oh gosh, now I'm a blank, but they charge based on submission, so not percentage, but every time they
so per click.
Yes.
Okay.
So every time we submit a claim, it's X.
Yes.
Okay.
What about?
So sometimes you're on the positive, sometimes you're on the negative, just depending on the.
What about verification, posting, and working denials? How does that work?
Based on number of clicks.
Oh.
So, but here's where you have to. So we got the numbers. We're like, oh wow, this is so much less. But you got to ask the questions. Okay, so this is for 2,000 encounters. Okay, well, what if we exceed 2,000? Well, if you exceed 2,000, then it's going to be 30 cents per encounter that we have to work. Or 30. Oh. Okay, so and that is for whether or not you're doing prior auth, you're doing clearinghouse,
right.
You're doing posting of payments.
Right.
So when you add it all up, it was still a savings. Okay, it's still less, but still leaves some uncertainty.
Okay.
Right.
Right?
Because how many clicks are we talking about, and who does the clicks, and how do we count a click?
It's based on the number of counters, and you have to take their word for it, right? That this is what
There's
they do.
no way to verify.
So it's a completely different model, but their compensation is different.
Right.
I guess.
Exactly.
Now, of course.
So instead of doing a percentage of your collections, where you sort of always know you're going to, there's that shared investment, right? That this percentage, they are going to be motivated to get your money because they're getting a percentage of that.
Sure.
Okay. But this click, is that going to be the same thing? And I don't know. I don't know how I feel about that. I have to think about that some more.
Right, because whether they do it or not, they might not get anything, or they're automatically getting paid for it.
Exactly.
Sure.
Exactly.
Is there a way to track like clean claim percentage?
That's a good question. So we've actually gone to vendor number 2 because we have some questions about some claims that were posted, and we're asking for a printout of every single thing that was done. We haven't received response yet, but again, these are the questions you need to be on top of it. You need to ask those questions.
How many doctors would you know, though, even know what clean claim is? I could guarantee you most of them have no idea.
Sure.
You are absolutely right.
And I think another big thing that you might be facing and that I always like to look at is, what is this company going to be like to get all of your data out?
Right.
That's a good question. That's a really good question.
What I was told that if I leave vendor number 2, I will have to. They will continue to take a percentage of my collections, but they won't transfer those encounters that were
billed
through their company. And so I'll still be paying for that while I make the transition.
Okay.
The other thing you have to factor in, and this is, again, what I have to think about, is how much money is it going to cost me and how long am I going to continue to practice? I'm not 25, but I've been doing this for 25 years.
Sure.
And so is it going to be worthwhile for me? And,
how hard is it to get that? Are they going to, because, this data migration from one system to another, they probably aren't going to be happy that you're leaving. So I don't know.
One thing they do, I do know they do, is they'll leave access. In other words, you can negotiate this, because I've done this.
Yes.
And say, like, look, on termination for any reason, you vendor number 2, you agree to leave access to the claims data to our folks for a period of 1 year or however many years, because once you pass 180 days receivable, I mean it's your collection percentage seems to drop significantly. So,
yeah.
but still you have access to the claim data. So if you're having people you're paying working them, you can still work those claims if you decide to do that.
I was told that was not possible by vendor number 2.
Wow.
And that we would have to continue to basically they would take a percentage of whatever we collected. Again, look, all these things didn't really think about beforehand. Sure. And that's why I'm here. I want to share it with the physicians. And
well, it's kind of like getting married. I mean, you're getting married to this vendor, and then you don't think about this because you're so happy that they're doing the platinum service and all this other stuff. And then you're thinking about, wow, I don't think I'll ever leave. But then when you do, you realize, wait a minute, this was not. You never told me this.
And how do I get my stuff?
Right.
And how hard is it going to be to move things around and over? So is vendor number 3? Because I know this comes up a lot. Are they going to help you get your data out of vendor number 2, or do they say, no, that's your problem?
So vendor number 3, this is interesting. It's something that needs to be discussed, is actually going to be provided to me at a significantly reduced cost because I'm in my hospital's quality network, and so they're going to pay 80% of the initiation fee. Okay. Had I not been in the hospital quality network, I would not be able to afford this product. It also makes me a little uncomfortable because then I have I'm tied to the hospital. What if something changed in my practice? What if I decided to switch all my care to the neighboring hospital?
Sure.
For whatever reason.
Sure.
So that EHR would only be available to me and an affordable if I continue my relationship with the current hospital that I do most of my business with and I'm very happy with.
Sure. That's like an ACO. I mean, that's just all
right.
Yeah. I would say that, and this is as past president of LSMS and my position on the board, that all the process of the whole revenue cycle and running a business, it can be very daunting. I will tell you that LSMS has really tried to establish resources for physicians. We actually are hosting a mini lecture series at the Capitol during White Coat Wednesday, where we'll have 3 experts come talk about the revenue cycle to start educating physicians. And if it goes well, we'll start hosting lectures across the state, because one thing that we did not get in medical school was enough business training. I don't know if they do it now.
They really don't. Let me just tell you this. I spoke to a group of fellows last week, and they put on a little mini series within LSU. And let me tell you, every single one was like, I wish I would have known about contracts or vendor agreements or my personal contract. I wish we would have gotten some business acumen in med school and in residency. And all they did was push clinics.
Yeah. The majority of physicians coming out today out of medical school residency are seeking employment.
Yes.
Majority are. I will tell you.
They don't know the practice model. They think the practice model is dead.
What they don't understand is how much freedom and satisfaction you can get from running your own practice.
Right.
I run my own practice. I set my own hours. I can go be with my children, which are now off to college. But it gives me the freedom to do what I want to do. And I enjoy that autonomy.
Let me ask you this. Rory and I have seen this in other specialties, MD VIP, concierge practice. Do you see that coming to OBGYN? Is that even on the radar? The reason I ask that is because I hear how you set your practice goals, and we do get asked about concierge and VIP status. So is that something you see in your specialty area? Is it even possible?
Yes,
Do.
absolutely.
What does that look like in your mind? I mean, I'm not telling you the prices or whatever. How far along down the road? What could that look like for patients? And I'm just curious if you thought about that. Maybe.
No, well, so I will tell you that I wear two hats.
Okay.
Okay. I run my practice, and I am a traditional OBGYN and robotic surgeon. I have about I do like 40% OB now, 60% GYN.
Got it.
And so then I did start a separate concierge type practice.
Oh, wow.
Yeah. But it's a very unique.
Mm-hmm.
Yes.
That's very interesting. I don't want you to say
but
anything.
I could say because I did it because insurance wasn't paying for this service for patients, and so it started off for.
I don't mean to get to this rabbit hole a little bit. I went down a rabbit hole.
It started off for cancer survivors, and it was sexual dysfunction. So I started a clinic for survivors of cancer for sexual dysfunction. Got additional training on that. They don't pay for that. Insurance doesn't pay for that.
Right.
So then I, from there, it's a cash only. It's an hour-long visit, and so it's a separate. So do I see concierge developing? Absolutely. As insurance companies basically focus more on population health and reduced reimbursement, if a patient wants that personal experience to really get their problem fixed, it's not going to happen in the 15-minute office visit.
Right.
And it's also not possible for a doctor to run a successful, safe practice with the current reimbursement. And I know patients probably think that we are being overpaid. Let me tell you, we're not. Okay, we are being overworked in some regards, and and having a concierge practice creates a safer, more personal environment that the consumer patient is looking
and
for.
I don't want to go down this rabbit hole, but I have said this to my students in law school or grad school, and I tell them, what's the first thing you hear of when you hear a politician get on the stand and say, we're going to make sure that you have high quality, low cost health care. That's a whole nother podcast, but I think I know what your answer would be, but let me get back on track. Vendor number 3, are you going with vendor number 3, staying with number 2, or has that decision been made? And what?
Honestly, I prefer to stay with number 2. I'll be honest with you. It's comfortable. I'm able to deliver good, safe care with vendor number 2. But financially, if the numbers don't work, I will be forced to change to number 3.
Well, let's say this. If you, and Rory, I could get to you too, I would say what were the takeaways? In other words, give us some of your top takeaways for doctors giving vendor agreements, your experience. What would you recommend they do, especially those who are seeking the entrepreneurial private practice route? What would you recommend to the physicians?
Number 1, as I said in the beginning, your accountant and your lawyer should be your best friends. I didn't understand the magnitude of that, but having been in business now for 25 years, I can absolutely say that is so important. It's also, and I'm going to speak to physicians and you will understand this, that if you go to If you have cervical cancer, your patient is not going to get that fixed by a gastroenterologist. If you have a contract, do not go to your brother or your dad to do it. Go to a contract attorney who understands healthcare law. I cannot say this enough. I actually come from a family of attorneys, and he actually gave me that advice. So I absolutely. The second thing is an accountant. I didn't share this with you, but I want to tell this from a business standpoint. I actually, about year number 5 in my practice manager at that time stole from me. I lost about, I know that's a whole nother podcast. We can talk about that later. But I lost about probably $250,000 to $500,000.
Wow.
Then one day we'll sit down and talk about that one.
Okay.
But my accountant is my other best friend. And so what I did is I created a lot of checks and balances within my practice. So if you ask me, do I have a practice manager? I have several practice managers, and I oversee everything. And I think that's important.
Sure.
This may seem daunting, but it is not impossible. And when you do it, you will have such a sense of pride and satisfaction. The last thing I would say is call on, use your resources. So Louisiana State Medical Society now has a private physician section. We're trying to develop it. Join. You do not have to be appointed to it to listen to the meetings, offer suggestions, and learn. Also, we are going to probably start offering conferences to educate, and then talk to people who have done it before. I think we need to help each other, because private practice is so important, because it is a different type of healthcare than your traditional corporate medicine model, and we can't let that end.
It's great. No, that's a great summary. I think we're good to end on that, and I definitely appreciate you coming and sharing all this information with us.
Agree. You know what? I'm going to have to schedule for more podcasts, because every time Dr. Williams comes in our studio, it's like the rabbit hole gets deeper. So we'll definitely have to have you back for some of these additional topics. So
sounds good.
Well, we really appreciate you coming. Thank you very much. Again, this wraps it up for us here at the Shahardi Sherman Health Law Talk Studio in Metairie, Louisiana. Send us a comment, email us, let us know what you think, any suggestions, you know how to get to us. We look forward to the next available episodes. Stay safe, be good, be well. Take care.
Thanks for listening to this episode of Health Law Talk, presented by Shahardi Sherman Williams. Please be sure to subscribe to our channel, make sure to give us that 5-star rating, and share with your friends. Shahardi Sherman Williams is providing this podcast as a public service. This podcast is for educational purposes only. This podcast does not constitute legal advice, nor does this podcast establish an attorney-client relationship. Reference to any specific product or entity does not count as an endorsement or recommendation by Shahardi Sherman Williams. The views expressed by guests on the show are their own, and their appearance does not imply an endorsement of them or their entity that they represent. Remember, please consult an attorney for your specific legal issues.